I truly believe that we can avoid diagnostic blocks and use a pulsed high-intensity ultrasound mode to block these nerves and to create this block of the nerve function temporarily instead of needles using the same energy. And it's not my dream because the preliminary studies were done, and when I was in the University of Washington, interestingly enough, that's exactly what we did with Professor Pierre Morat in biophysics lab. We tested high-intensity focused ultrasound as a neuromodulation device on animals. So I know it should work. The devil's in the details, so we need to figure out the frequencies, the energy, when it works, when it doesn't work, but that's the next step to avoid even nerve blocks with the needles.
Hello, this is Dr. Karmi for Chronic Pain Chronicles, and today we have a guest with us, Dr. Gofeld. Hi, Dr. Gofeld.
Hi, Dr. Karmi.
Dr. Gofeld, I guess, career has some general parallels with my own. We both, I think, started in former Soviet Union. We both ended up in Canada. Both of us ended up treating patients with chronic pain, albeit using different approaches. Just in a way of introduction, certainly when I remember chronic pain over 20 years ago when I started in the field, it wasn't really well known. Most physicians didn't even know the field existed. How did you end up getting into pain management?
It's a good question. First of all, thank you for inviting me. I ended up in the pain management really by mistake. Well, not really mistake. I was a resident in anesthesiology, and I had to do 3 months of chronic pain rotation. And I did my pain residency in Israel and the University of Tel Aviv. So I was sent to a pain clinic, and I had very vague idea what pain clinic is about. And I couldn't help but feel that everyone gets the same approach. So everyone who get in with a back pain will get epidural, blind. And some people with headache will get some occipital nerve block. And I had just I started asking questions. And at that time, my supervisor said, well, just don't ask questions, do what you ask to do. And 3 months, I did not get passed out of pain clinic. Actually, I was pretty much fed up because the other resident, I can't remember, she was sick or whatever. So I stayed another 3 months, and I started reading, and I said, it's actually a fairly interesting field because I came across of J.J. Bonica pain management, and I decided it's very fascinating. And basically at that moment, I decided to jump in and continue my career in the pain rather than anesthesia.
Wow.
So the rest is a history, right?
So I guess fast forward to today, and I wanted to talk a little bit about what you're doing now. And what you're doing now is treating back pain with ultrasound. And again, now I'm not talking the kind of ultrasound that physiotherapists use.
Mm-hmm.
This is actually interventional procedure done in pain clinics. So can you tell me a little bit about that?
Sure. First of all, my interest in ultrasound actually started from spine ultrasound. I think at that time I was in Sunnybrook, and I was fascinated by work that was done by European colleagues on spine. And we in Canada, even now, we're limited in access to operating rooms and fluoroscopy. And back in 2007, it was even worse. So I came across of work of European colleagues from Austria, and I said, well, it looks interesting. Like Manfred Greher published that time, Urs Eichenberger, and that's how I came to the field of ultrasound guidance. So fast forward, I actually did my PhD in spinal sonography, and I expanded to some research and development. And in about 8 years ago, I was asked to be a consultant of a small startup. The idea of the startup was, in my mind, pretty crazy because they said, okay, we'll just take a high-intensity focused ultrasound. And at that time, it was available only in a big machines like MRI. And they hope to minimize it to a sort of clinical use and apply this energy for the same application that we've been using for like this radio frequency for spine pain. And so I joined them, and that's basically was a journey of 8 years. So in a nutshell, basically it's called a high intensity focused ultrasound, which is not new in the field, but the portability is new. So basically, and anyone who is not familiar with the field, any energy, if you focus, being electric energy, optic energy, magnetic energy, will produce some tissue effects. And focused ultrasound produce two effects. Why? It's a tissue shaking. It's called histotrypsy, which is not what we use for pain, and heating, like heat effect. And heat is very energy dependent. So the high energy, the higher heat produced, and the lesion size is growing. Now, from the terms of technological advantage and technological ingenuity of this process, of this device, is not in the principle, but in the guidelines, in trying and successfully departing from a MRI. Because MRI is a great imaging, and it requires two beams that converge, and it's basically called coherence ultrasound that will produce a grain shape lesion, which is being used, for example, in a brain HIFU in Sunnybrook and Toronto Western for the treatment of Parkinson's disease and essential tremors. That's not what the machine is called now, Neurolyzer XR is using. It's using incoherent ultrasound. So incoherent ultrasound produces like an area of about 5 centimeters that is diffused imaging because multiple beams going from different directions and confusing each other. Except in this area of this range, all these beams will meet a bone tissue. And because of bone absorption of ultrasound is very high, it will create a blast. The lesion will grow from the bone outside, like a mushroom. But actually, the shape of the lesion in animal studies and the in silico studies, it looks like a Hershey chocolate, like a drop. So that's exactly how lesion looks like. And because of this is incoherent mode, anytime it's directed under the X-ray to the bone with a specific location, such as medial branch, it will create the lesion. So this is the ingenuity of this device, and that allowed to depart from MRI to very simple and convenient imaging such as fluoroscopy that most of us have been using forever. And the target is pretty much the same. So that's another point. You don't need to recreate sort of your mechanics in the brain to find the target. The technique is different, but the imaging technique, the imaging modality, and the target is pretty much the same.
So just to clarify for the audience, again,
Sure.
there's multiple types of ultrasound. There's the therapeutic ultrasound that's used by physiotherapists. There is ultrasound that you started with, which is simply used to create images. And then there's high intensity focused ultrasound, which is actually used to destroy tissue or heat up the tissue. And then it comes, you're telling me, in two flavors. One flavor that is used for brain surgery, so to speak, under MRI guidance. And then there's the non-coherent flavor, which is the novelty, I assume, which creates these Hershey Kisses shaped lesion. That's the one that you're working on.
Yeah.
So what is the fundamental difference between these? I guess one is non-coherent, one is coherent, but how are they different from imaging ultrasound or ultrasound that physiotherapists use?
Sure. So we need to remember that even ultrasound, diagnostic ultrasound, still delivers thermal energy and histotrypsy energy. And there are tables that attached to any machine, digital tables or actual tables, that is specifically used in neonatology, because there there are limitations how much ultrasound a technician can deliver to a baby without making some brain damage that, for example, brain imaging ultrasound. Even diagnostic ultrasound, still there is a emission and receiving. Ultrasound goes both ways. We call it transducer, but basically it's not just transducer, it's an emission and an emitter and receiver at the same time. So the transducer emits ultrasound waves. It goes through multiple layers and different tissues. Because of different speed, it creates different permeability and reflection back. And this reflection back changes piezoelectric crystals, creates electrical signals, and we see it in the imaging, okay? So this is diagnostic ultrasound. Therapeutic ultrasound that physiotherapy used is also sort of incoherent ultrasonography because, I mean, even if something is coming back, there is no registration. It's more dense area and it creates a heating and some gentle vibratory effect on the tissue, right? But it does not lead to a tissue charring, a tissue lesion because energy is very limited. It's rarely go more than 100 joules energy. And with a high intensity focused ultrasound, that energy can go anywhere up to 10,000 joules, which can create a hole in a bone like a laser. But obviously we don't do it. So in pain applications, we are usually use a range between 1,000 and 1,500 joules that can create a good sized lesion without exponentially increasing. By the way, with other machines, there's not just MR guided. There's also ultrasound guided systems that mostly used for oncology applications, prostate cancer, breast cancer, or uterine fibroids and host of other conditions, but they're also very bulky and very costly machines.
Again, just to clarify, there's sort of two machines involved. One is obviously the MRI machine, which traditional high-intensity ultrasound will use, that are obviously very large. And then there's the actual ultrasound machine, which is generating the waves. So clearly advantage of this new approach is that, first of all, you can just use an X-ray machine, which is much more portable than MRI machine. But then are you saying that the actually ultrasound machine that's generating waves is also more portable than what's typically used for brain surgery?
Yes, yeah. So the cradle that we use is smaller and it's mobile. And the cradle, like a ring with piezoelectric circles that creates different waves. And this is a transducer. So it's connected to a portable machine. Size is a radio frequency generator that anyone who's familiar with a radio frequency generator, not so large. And there's an electronic connection to a fluoroscopy machine because you need to realign two imaging modalities, optic modality and X-ray modality, right? And so it's actually using some sort of augmented reality to overlay two images, which is, again, not nothing new about it because many imaging and procedural imaging is use this overlay. So we overlay CAT scan on X-ray or MRI on ultrasounds, but here it's overlay the optic positioning system on a patient's skin to a fluoroscopy machine to basically find the right target. All right. And then the energy can be delivered. So I have actually a pretty simple and cool animation. If you like, I can try and then run it and explain on animation sites how actually it works. Maybe one picture worth 1,000 words.
So fundamentally, what you're doing is you're treating facet joints, primarily, I assume, of lumbosacral spine. I'm not sure if you've extended it to treating sacroiliac joints or the back as well. And so what is the experience like? I assume you're still going to have to start with diagnostic blocks to decide whether or not patient would qualify for the procedure.
Yeah, the diagnostic work is the same as for lumbar radiofrequency ablation, neurotomy. The device from the beginning was designed to the first target as lumbar spine. is a labeled application to lumbar spine. So Health Canada application, Health Canada approval is for lumbar spine. But that being said, I have used it for sacroiliac joint ablation because it's fairly simple and easy. There is a study going on in the University of West Virginia and on a sacroiliac joint formerly using the same device. So there's not much departure from anything that we know. But from the research standpoint, we have now studies that was done first in 2021. I participated and colleagues in McGill. So there was a pilot study. And then we continued study our clinic together with Toronto Western Hospital. We did so-called Canadian pivotal study for Health Canada approval. And it was only patients for lumbar spine, or facet joints. And the study in FDA, pivotal study on 80 or 90 patients, is finished in the United States. And now the article is being written up and FDA is submitted. So who knows how long it will take. I don't think it will take more than 6 months. So coming back, our clinical experience and research experience mostly and primary as a lumbar area and related to facet joints. So the workup is the same. So clinical diagnosis of patients who have primarily axial low back pain, mostly elderly patients, and some clinical predictors and diagnostic medial branch block. The next step is, I believe that since we're talking about developments and cool stuff, I truly believe that we can avoid diagnostic blocks and use a pulsed high-intensity ultrasound mode to block these nerves. And to create this block of the nerve function temporarily, instead of needles using the same energy. And it's not my dream because the preliminary studies were done. And when I was in the University of Washington, interestingly enough, that's exactly what we did with Professor Pierre Morat in biophysics lab. We tested high-intensity focused ultrasound as a neuromodulation device on animals. So I know it should work. The devil's in the details, so we need to figure out the frequencies, the energy, when it works, when it doesn't work, but that's the next step to avoid even nerve blocks with the needles.
I'm not, honestly, I know of pulsed radio frequency. I heard of it as a therapeutic approach in and of itself, in its own right, especially sometimes for lumbar, but sometimes even for mixed nerves where you wouldn't want to destroy them. But I actually don't have any personal experience with it. Does it actually numb the nerve? What
We're
happens?
talking about pulsed radio
Pulsed
frequency.
radio frequency, yeah.
So pulsed radio frequency, the theory behind pulsed radio frequency is electromagnetic load with 500 megahertz with energy of up to 50 watts to up to 5 minutes, delivered on a nerve tissue. And to be honest, it has never been proved in any clinical setting, but on a cell culture and an animal setting, the theory behind it that is preferentially influence of C fibers and leaving other nerve fibers intact. And how it influences on the C fibers, because they're unmyelinated, so it would increase the threshold of the action potential by about 5 millivolts. And by increasing this threshold, basically meaning the pain propagation, the action potential is ceased or decreased. That's the theory behind pulsed radio frequency. Now, no one in the clinical world ever proved that actually it happens. But based on some studies and evidence and clinical experience, it looks like it works better than any nerve blocks with local anesthetics. My personal experience with research on pulsed radio frequency is a study that we tried to do in Sunnybrook on patients with shoulder pain and double blind and randomized. And it definitely proved that patients who received blindly and randomly pulsed radio frequency of suprascapular block, the pain relief was longer and better than the patients who received suprascapular nerve block. So that's the theory behind pulsed radio frequency.
I don't know if you have personal experience with it. What I'm really asking is, you do pulsed radio frequency. I suppose you put some anesthetic in there as well when you do it. So it's hard to know. Does pulsed radio frequency on its own create numbness?
It should not create numbness.
Okay.
No, it should not create. It should create only pain, reduction of pain.
Okay. So fundamentally, where this is going is that right now the procedure requires a single injection to make diagnosis, and then after that, all the rest of the treatments will no longer require injection. And potentially in the future, one could bypass injections completely and just use this treatment to treat back pain, right?
That's pretty much, but again, it's all regulations, right? So in the United States, for example, insurances will not cover radio frequency unless 2 comparative blocks are done. Right? In Canada, there are no regulations. I know, and I personally do the same. If the patient's clinical picture is fairly congruent with axial facetogenic pain, I may not even do diagnostic block because we can talk about problems and biases of diagnostic block for another 2 hours. But if put it in a scientific way, Steve Cohen, he was in Walter Reed Hospital now in Northwestern, he published a series of articles, very clever articles, showing that bottom line, the difference between 2 very precise diagnostic blocks and no diagnostic blocks, radio frequency ablation, the difference is about 10%. So given the fact that radio frequency is today is very safe procedure, so why bother to do diagnostic block if the clinical picture is very straightforward?
So you're saying that clinical picture predicts things almost as well as diagnostic blocks.
Absolutely. Bottom line, about 50% of people without diagnostic blocks based on a clinical picture will receive a fairly reasonable results for radio frequency. And if you apply all kind of bells and whistles, 2 diagnostic blocks, blind, so you can increase this probability to 60%. So is it worth it to invest time and subject patient for another 2 fairly uncomfortable procedures if you just can skip and do radio frequency? The history behind diagnostic block is actually going way, way back to the start of radio frequency, because when radio frequency just started, remember, it was 12-gauge blunt needle called ray electrode, like a harpoon. So that would make sense because the morbidity was pretty high and the procedure time was very low with radio frequency. So now it's more historical, and I think historical concept, if it's just for the protocol to do diagnostic blocks. So I use fairly simple way to distinguish between, or to find out if a person has a high probability of facet pain. It's age more than 55. It's radiological confirmation of the facet arthropathy of spondylosis. It's a pain aggravated by movement and subsided by recumbency or rest. And preferentially, it will be out to one side pain with aggravated by twisting movements and extension, which kind of more or less predictable because some people with flexion also has facetogenic pain. But if I just tell like age, relief by rest, and the site of pain with no neurological feature, that will be almost 100%. Those people will be with at least some component of facet-generated pain.
So it sounds like you can do this treatment and completely avoid injections.
Correct.
But does that mean the procedure is painless?
No, that's not. I don't know if to curse you or thank you for asking this question, but that's a difference it's a perfect example of difference between research and a clinical practice. Because when we did our research, and including, by the way, American research, which I was surprised, just a few patients reported pain during this procedure that they could not tolerate without any sedatives. Just literally a few, a handful. Now, when we are now almost 30 patients out in the clinical, right, it's not. Some patients really have 0 pain during the procedure, but some patients have 10 out of 10 pain and need to provide some sedation. Or last week, I hated to do that, but I had to do facet joint blocks to continue non-invasive ablation of the joints because a person could not tolerate it. It looks like the procedure itself is more painful than radiofrequency, again, based on the fact that radiofrequency, even without sedation, that most of the time we do sedation, but even without sedation, once the cannula is placed or on the way the placement of cannula, we provide local anesthesia and also freeze the site of lesion. That's not in this case. So
okay, I guess just a sideline, I could be totally off base, but are there any factors that could predict whether or not somebody would experience pain with this procedure or not? Maybe if they have a big myofascial component or neurosensitization, like fibromyalgia type patients?
It's also very interesting predictor. Patients who complain that their background pain more than 9, so 9, 10, like those patients, have a higher pain during the procedure. You can say they already have 9 or 10 pain, so how worse it could be. So yeah, apparently. And also those patients, most of them would fail. And we could see it in the studies as well. So patients who reported 9, 10 out of 10 pain, generally speaking, they are very poor responders. Other than that, yeah, you already pretty much guessed right. So the patient with fibromyalgia, a patient with generalized anxiety, patients with diffuse myofascial pain, sure, they will have any type of pain sensitivity or hypersensitivity or central type of centralization of pain. They will have much higher procedural pain, which is not surprising.
So are there any side effects or contraindications to this procedure?
So first of all, patient size. So very skinny patients when the distance between skin and the medial branch is less than 3 centimeters. Believe it or not, we have those patients. Or patients, conversely, when the distance is more than 10 centimeters. So the beam will not reach the point of increasing temperature on these patients, and a skinny patient can burn skin. Some contraindication that I've never seen yet, but it's like a hypertrophic scar, because it will be very difficult to place the gel and create the sealed environment if it's a hypertrophic scar. But on the other hand, patients do not need to stop anticoagulants. There is no need. Patients with implanted defibrillator that are excluded from radiofrequency ablation, by no means you can treat it. Patient with metal post-surgery, as long as the metal is not on the way of the beam, the patients can be treated. And all these issues that are difficult with radiofrequency, because as I said, anticoagulants now is more lenient, but still many doctors require to stop anticoagulants. Implanted defibrillators is no go with radiofrequency. And the metal is not really per se is contraindicated, but when the metal is present, all radiofrequency energy, which is electric energy, is focused on the metal, right? So it will be basically a big grounding pad implanted in the patient body. So the lesion size will never reach the size of ablation. So it actually expanded areas of applications. I also think a patient with severe scoliosis, they will be not a good candidate for HIFU, only because it will be very difficult to adjust the cradle on the patient's skin. But those pretty much are contraindications. There are no really absolute contraindications, all in relative contraindications.
2 follow-on questions.
Okay.
One is, since you have interest in spine, can one do HIFU with ultrasound guidance? And a somewhat related question, can one do high-intensity focused ultrasound on pregnant patients?
With this device on the pregnant patients, no, because it still requires fluoroscopy imaging. It's a fluoroscopy guided high-intensity focused ultrasound. Right. People have some cognitive dissonance that, oh, it's ultrasound or fluoroscopy. It's a fluoroscopy guided high-intensity focused ultrasound. Now, the The next generation is called, that's why it's called Neurolyzer. Remember the Neurolyzer in Men in Black? So that's where the idea came from, Neurolyzer. But in the movie, it's with Z, and this machine I talk about with S, probably because of the not to go to patent infringement. It's called Neurolyzer XR. XR stands for X-ray. The next generation the company is working on is Neurolyzer US, which is exactly what you just said. It's ultrasound guided, high intensity focused ultrasound. And it's a smaller system, very clever, because in contrary to fluoroscopy, X-ray, ultrasound also knows how to identify the depths, right?
Yeah.
So in this case, this augmented reality works pretty good because the sensor will focus the beam exactly on the depths that is necessary, right? But I think it will be great for joints, like denervation or of joints that now is being used only with radio frequency, maybe some other applications, maybe even oncology applications. I'll be very cautious about spine. It certainly can be done, but because the transducer itself, the imaging transducer, is pretty small, it may not fit patients with a good size. But at that time, when it's available, and again, my prediction will be available within 6 months, because the approval process will be fast. The moment the GLP good practice study is finished, which has been done now, it will be straightforward application for regulatory approval. But I don't think it will work ultimately for patients with increased body mass index on lumbar spine. Thoracic spine, I guess it will work. Cervical spine, it will be probably wonderful application. Peripheral joints, maybe even soft tissue. The future will show. You know how it goes. Usually some clever PhDs in inventing a method and doctors will try it for different applications. I can see it in different ways, but ultrasound system is on the way.
And okay, so we talked about some of the contraindications. So let's talk a little bit about effectiveness. So how does it compare in terms of effectiveness to standard radio frequency ablation? I'm assuming you didn't do side-by-side studies. This is just your initial impressions?
So we did side-by-side imaging study, and it's kind of interesting story behind it. Because the application for FDA was under 510K de novo, which basically something that is known, but there's some element of unknown. So FDA asked the company to produce a comparative study on animals first. So the first study was done and published on pigs. One side was done with standard radiofrequency, the other side was done with HIFU, and MRI and histology was done after. So HIFU was by far better than radiofrequency. Radiofrequency produced only 50% visible lesions, and HIFU in the lowest energy produced 71% of lesions, and a high energy up to 96. But FDA is pretty tricky organization. So they said, okay, fine, we're happy you did it. But can you show us any study on MRI after radiofrequencies on humans so we can corroborate? And to my astonishment, I did not find any study. It was nothing, zero. Later, one of American colleagues produced some study, but it was not quite relevant. So what we did study ourselves, we already had studied MRI after HIFU with a fairly significant, depends how you look at correlation, association with the pain relief, size of the lesion, and presence of the lesion on MRI. But we did it the same with radio frequency. And when we did it radio frequency, the results, radio frequency on humans, basically people who went to us to have radio frequency, and we offered them to do a free MRI 5 days after, and 10 patients sign up, and we did it. So again, it was also shocking that only in 26% of these patients were found visible lesion on MRI. So we don't have clinical comparison, but imaging comparison is by far better of HIFU.
Did I understand you correctly? Only 26% of people with traditional radio frequency ablation were found to have lesions.
Yeah.
And what, 100% of patients with HIFU ended up with?
No, not 100%. We found 50% had a lesion and up to 70% have edema, which is, by the way, secondary effect of heating, right? Not the lesion, but edema. We could not take histology study on patients, right? But when the differences are clinically difference, first of all, difference between radiofrequency and HIFU, it's more painful, as I said, more painful during the procedure, but after the procedure, within 10, 15 minutes, the procedural pain is gone, as well as low back pain. Radiofrequency patients, because of the needle, because of whatever it's going on, they often have sort of protracted back pain for a few days up to even a couple of weeks, or sometimes longer. And it's probably because of muscle damage of the needling. HIFU patients obviously don't have needling, so responders are usually responding almost instantaneously. Now, for how long? I think it's actually fairly similar to radiofrequency, probably somewhat better, just based on the study results. But if you take statistically, it's within the same range of up to a year pain relief, reasonable pain relief, up to 50% still pain relief. But I just repeated HIFU on the patients who were in our first study, which is 3 years after. And some of them, believe it or not, they said, I still feel better. My pain is returned. But if I compare it with how it was before the study procedure, it's still better. So I will not make a frivolous comments because, oh, yeah, it's a wonderful and the pain will be gone forever. But it looks like it works for longer than radiofrequency.
So again, the size of the lesion, I always thought of as a little bit of a double-edged sword. You make the lesion too big, you might catch some of the nerves that innervate paraspinal muscles, and I'm always worried, could it spread and affect the root? You make it too small, you don't catch enough of the nerve, and then you don't have a very long effect. Any thoughts relating to
how do we deal with this? Okay, so first of all, nerve root is not, because it's actually protected by bone. So the bone of the pedicle is protecting from the beam going to the nerve root, right? Radiofrequency cannula erroneously placed right right there, but here it hits the bone and it protects. Now, because as I said, it's incoherent, you can technically pass this beams through spinal cord and nothing will happen, because within this 5 centimeter incoherent, we call it therapeutic envelope, the temperature increases up to 42 to 43 degrees, which is non-lesional temperature, and then it dissipates. So it goes like conus and it goes continue dissipating. So that's number one. Number two, in all studies in clinical cases, it's now probably like around 200 cases worldwide, there were no any nerve root damage whatsoever. Number three, about the size. I agree, and this extended discussions to create a radiofrequency or other lesion, and you can catch lateral branch, intermediate branch, and motor branches to multifidus muscle, etc. When I said the target is the same, I made it a little bit more oversimplified, because the target is the same for the ideal target. Because for lumbar medial branches is actually focused on the very low part of the pedicle where only sensory branches of facet joint remains. And the radiofrequency there cannot be done because the mammal accessory ligament is sheltering medial branch. For HIFU is actually a bonus, this mammal accessory ligament, because it's concentrate in energy. It actually creates a sparing effect. At least our theory in models shows that it creates a sheltering sort of effect on other twigs or branches and ablates only articular branches, right? It will be good to show it more experimentally, but I think it will be the next project on a patient. So there's not much, and the lesion size is a dose dependent. So with 1,000 joules on a normal size patient, it will be about 1 centimeter shape, same as a cooled RF or tined RF in ideal world, right? And on a more high kind of weight patients, it's 1,500 joules. It's not because to increase the lesion, it's just to create the same lesion because you need to deliver more energy through depth of the tissue. Okay, so I do not think it will create any problems with muscles or any other structures.
You talked about pulsed radio frequency as a possible application. You talked about maybe broadening to other targets, possibly using ultrasound guided rather than fluoroscopy guided procedures in the future. Any other thoughts on what the future holds for this approach?
If you go and send your audience to FAST Foundation website, there's a Focused Ultrasound Foundation.
Mm-hmm.
You'll find, I don't know, maybe not hundreds, but multiple studies that are going on in different applications, including what is kind of in our field. There are few studies going in neurology and few studies that are going in oncology for bone metastasis, soft tissue metastasis, and some other studies trying to figure out what is the neuromodulating potential of high-intensity focused ultrasound. And other studies show that sonication with high-intensity focused ultrasound after surgeries and then injecting regenerative medicine there would increase the proliferation of fibroblasts. So there are plenty of study there. Brain imaging is probably will be exploding. Sunnybrook just finished, as you probably know, they just finished the study on high-intensity focused ultrasound to treat severe OCD with very good results. But I don't think anytime soon in the pain clinics will own our guided machines. So we'll stick with a portable. But I would say if I had an option to create a histotripsy, for example, in a small machine, which is currently unavailable, that will be a great for any sport injuries, for calcific tendinopathy. Now we send patients for shockwave therapy of the calcific tendinopathy, and honestly, it doesn't really work well because A, it's a low energy, and B, physiotherapists don't focus it right. So that will be great. But for now, we have some technological problems. I can imagine that if we can block nerves, just do a nerve block non-invasively, that will be great for regional anesthesia. So who will need to inject medications? Reimbursement is a separate issue, right? So if you cannot bill for this, I don't know if a doctor will do it. But practically, it can be pretty cool if you can do all nerve blocks without even injecting anything.
You put us all out of business.
I don't know. Maybe we'll all be out of business, or we'll advocate to change codes because if we did produce nerve block, who cares how did we do it, right?
Thank you for talking to us about needle-free interventional procedure to treat back pain. I found it very informative, and we will post some additional information on our Instagram and our website, hopefully with a video on how this is done. Thank you, Dr. Gofeld.
Thank you, Dr. Karmi, talking to me.
So what are my final thoughts on high-intensity focused ultrasound? Well, first of all, let me make it clear that this is not going to fix everyone with back pain. Assuming it works as well as traditional radio frequency ablation, it will likely help about 15% of patients with chronic pain. Also, even though this procedure does not involve injections, it is not a pain-free procedure because you are still destroying tissue. Setting these qualifiers aside, I still feel it is a huge advance in interventional pain management. This is the first interventional pain procedure which can be performed without penetrating the skin with a needle. There are many patients who are terrified of needles, who would refuse most types of interventional pain procedures, but who would be willing to undergo high-intensity focused ultrasound. The company behind this device is called Fusmobile, and it is rolling out Neurolyzer XR in stages. At this point, the only clinic offering high-intensity focused ultrasound treatments in Ontario is Unica Medical Center in Toronto, where Dr. Gofeld works. Presumably, as the company gains more experience with outcomes of this procedure, they will allow additional clinics in Ontario to offer this procedure. This is not unlike our stem cell study for osteoarthritis, which at this time is just limited to my clinic in Brampton, but will eventually be broadened to include other clinics as we gain more experience with the stem cell injections. Thank you.
Thank you for listening to this episode of Chronic Pain Chronicles with Dr. Carmi. You'll find a link in the episode description to an explanation and animation by Unica on non-invasive HIFU treatment for lower back pain. If you enjoyed today's discussion, be sure to follow or subscribe so you don't miss what's coming next. Until then, take care and remember, you're not alone on this journey. I'm Ravina Ojla. Till next time. Disclaimer: when it comes to your health, always consult with your own physician or healthcare provider for personalized advice and guidance. The information provided in this podcast is for educational and informational purposes only and should not be considered medical advice or a substitute for professional medical care.